Jason.
All right, we are ready to resume programming, everyone, with new and improved closed captioning. I want to introduce our next speaker. Our next speaker is Dr. Stephen Herwig. Dr. Stephen Herwig is a retired head and neck surgeon and physician with over 20 years of experience. Dr. Herwig has a long history of action on the topic of dying with dignity, having served in the medical field in championing education, compassion, and building relationships. I'm really looking forward to hearing this one. Please join me in welcoming Dr. Stephen Herwig.
Thank you. Actually, I practiced for 34 years, but I've been retired for 11, so, and 31 of those years are for practice here in the metropolitan area. Anyway, thank you for inviting me to talk to you today. And this is a pretty enlightened group, so for a lot of you, this may be redundant. Maybe I'll have one or two pearls or something that you haven't thought about in terms of preparing for the end of life. I want to thank Warren Stein for letting us use the Stein barn. I grew up on a farm until I was in 8th grade, and then we built a home in the city where I grew up and moved there. So I think barn is a little unusual. This is the only barn that I've ever been in that I felt I had to wipe my shoes before I got in. So anyway, so we'll get started, and I'll talk to you about preparing for the final journey, and you'll hear words today such as quality of life, values, communication, and the thing I'd like you to think about is, as you've gone through your lives, important events you planned for. You didn't let them go willy-nilly. For instance, when you got married, that was probably for those who were married. You probably spent quite a bit of time preparing for the ceremony. When you went off to college or whatever it was after high school or trade school, you probably did quite a bit of thinking about that. So what I'd like you to think about is the planning for the end of your life so it meets what you wish for yourself, that your values and your beliefs are inculcated into the choices that you make for the end of life, and why communicating that is really critical to making sure that your wishes are honored. So what I encourage you to do is put your personal beliefs and values into every decision that you make. Any decision you make medically, any decision you make about the end of life. And is it more important that you have quantity of life, that you have lots of years, or that you have quality of life, and you pick how you want things to end, depending on what your health circumstances are at the end of life. You'll have choices to make in terms of what treatments or interventions you want for yourself, and that should probably be based on what your condition is. And we'll talk about planning. By the way, on the table, there are 3 things that you're welcome to pick up. My end-of-life decisions was kind of a planning guide, your end-of-life priorities, and then there's a resource sheet, because most of the things I'm going to talk to you about today, you can access or download for free, and they're on that resource sheet, so feel free to take that with you. The Conversation Project was something that was started by Ellen Goodman for years ago. She was a writer for the Boston Globe. And in 2010, she and some other people co-founded the Institute for Healthcare Improvement. And the Conversation Project was one of the outgrowths of that. And the conversation was trying to get people to think about having that conversation with their loved ones to explain what they would want for themselves. Because if you don't start with a conversation, then maybe all is lost. So it's getting to that point. So you can download the conversation page. All of these things are free. 92% of Americans think it's important to talk about the end of life, but sadly, only about a third of the people actually act on that. So we're trying to take good intentions into an action step. Also with the Institute of Healthcare Improvement, they did a study called Dying in America back in 2014. And what they wanted to know is, why don't people talk more about events surrounding planning for the end of life? And so the reasons that were given are, as you see on the screen: not important, don't want to be bothered, my loved ones don't want to be bothered. We'll talk about the taboos about talking about death and how sometimes that is an impediment. So what they came up with, recognizing what are some of those impediments, how do we move beyond that? And so what they wanted people to think about is thinking about this as an ongoing process. I was thinking about when people clean their house, the people will say, don't think about cleaning your whole house. You think about cleaning one room at a time. And that makes the process, you break it down into steps. So if you initiate the conversation, you can add to that later on. You can increase the depth of the conversation as your circumstances change, as your health changes, as you age, that sort of thing. The benefits of that is that at the end of your life, when people know what your wishes are, there's less confusion, less family rancor. You have a much better chance of having your wishes honored if they know about that. It is truly a gift of love. You give to your family. When you do that, you take the step so that they understand what your wishes are and they're not left to guess. And then as a mentor to those in your family, you set a pattern that hopefully they will follow when they age. A third of seriously ill people are receiving invasive treatments that they didn't want. And that's kind of sad. One, it's sad that they're receiving those treatments that they didn't want, and two, that they're going through the expense of receiving those treatments that they didn't want. Imposing your values on every healthcare decision. Talking about death won't bring death sooner, but it may help to clarify what your wishes are. My mother-in-law, I grew up in Wisconsin. My wife and I are high school sweethearts, and her mom at the end of her life was experiencing healthcare problems. And so she would go to the hospital, she'd have a procedure done, she would go to rehabilitation, and then she would go back to the senior center where she resided. And my wife, for about 6 months, was spending Monday through Friday pretty much in Wisconsin with her mom and coming home on weekends. And at one point, my wife was coming home for the weekend. She got as far as Dubuque, and she got a call that says, well, Jerry's had a relapse. So my wife cried all the way back to the Madison area where her mother was going through the process again. So ultimately, Jerry made the decision. She says, I can't have you keep coming home, Karen, to look after me. I'll just move to Des Moines to be closer to you. So she moved into Wesley-on-Grand, and she was there for a while, in independent living, ultimately kind of moved into the health center side. And she had another relapse. She had another bowel obstruction. So it was an emergency. They took her to Methodist for care. When you have a bowel obstruction, first you have to decompress the stomach, and then you have to wait either for the bowel to open up, or sometimes you have to go in surgically to remove the bowel impaction. And Jerry reached kind of the end point where she said, I really don't want anything more done. Well, if you're in the hospital, you know that it's not a hotel. You can't just sit there. You have to either make a decision, something's going to be done, i.e. you're going to have a procedure, you're going to move to hospice, something else. So what they did is they actually asked for the palliative care team to come and chat with Jerry. So the palliative care physician came. He sat down at her bedside and spent an hour with her. He said, Jerry, if you don't want surgery, you don't have to have surgery. And my mother-in-law said, finally, somebody's listening to what I want. So it was after that she got moved to hospice, and she was ready to die. She had lived what she wanted. She didn't want any more procedures. So she was in hospice for about 6 months until she ultimately died. I'll tell you kind of a gallows humor thing about that. My wife's grandmother had made the decision that when she died, she was going to donate her body to the University of Wisconsin Medical School, and Grandma did that. Karen's mother decided she was going to do the same thing, but when she moved here from Wisconsin, in order to transfer a body across state lines, the body has to be embalmed. They can't do that to use it for anatomic study. So she ultimately ended up donating her body to Des Moines University, which is my alma mater. And the joke that my mother-in-law made, she says, that's too bad. I always wanted to go to the University of Wisconsin. So, moving on. Death talk is taboo globally. For whatever reasons, we just don't want to bring up the subject. We feel it's uncomfortable, but if it's what you want for yourself, you have to take the initiative. You have to take the initiative with your family, with your caregiver. And what I would say about that is, because as we talk about, we're leading up to developing your advanced directive. And as you do that, when you have a conversation, this isn't a 10-minute office visit with your physician. So having been on the medical side of things, I would encourage you that if you do make an appointment, you want to talk about what you want for yourself, you ask for extended time. So maybe you're scheduled later in the day or whatever, so you get the time you need with your healthcare personnel. So you probably have to bring up the subject yourself. Don't wait for it to just kind of pop up, because your children are probably not likely to talk about it. They may think that that's something that you don't want. We're going to talk about advanced directives, and the thing about advanced directives, which are sometimes called living wills, is that the only time that they take effect is if you are unconscious or terminally ill. So there may be some misconceptions about the power of attorney for healthcare decisions that you grant to other people, but there's limited circumstances where you might be called on to make those decisions. But I'll talk about why that's important, that the person that you pick understand what your wishes are so they can separate themselves from the equation. If they have other beliefs for themselves, can they subjugate that to your wishes for what you want for yourself? And that sometimes involves balancing the quality of life versus the quantity of life, what you really want at the end of life. And I was thinking about, well, what would happen if we go home today and one of us has a heart attack, or one of us has a stroke, and we're left in a medically imperiled position, that we may find out that several hours later we're intubated in an intensive care unit. So these are the things that you don't want to wait for something bad to happen. Prepare for it ahead of time. Give it the careful thought that it deserves. Then who's going to make that decision for you? In a moment, I'll talk about all the decisions that somebody with the power of attorney for healthcare decisions may be called upon to make. And that's why it's not just calling somebody and saying, well, would you be my power of attorney, and then getting that name on the form. It really requires some in-depth conversation, especially if it's somebody who's not a member of your family. And talking about members of families, I know of a situation where it's actually my sister-in-law, and she knows that at the end of her life that my brother would not be able to say, stop doing everything. So she's given power of attorney to their daughter, who happens to be a nurse, because she thinks that her daughter will follow her wishes better because too emotionally draining for my brother. So these are kind of decisions. So it won't always be the spouse that has the power of attorney. So these are the things that your healthcare representative, your power of attorney, your surrogate, your proxy, whatever you might call it, these are the things that they may be called upon to do. And again, can they separate their wishes from what you want for yourself? And that sometimes can be hard if their belief system may be a little bit different than yours. The other thing is that person maybe dies before you do, so you're left in a position of having to find a different surrogate or power of attorney. So I'll talk about some conditions when you really need to look at your advance directive and make some changes with it. Accessibility is really critical in terms of who your power of attorney is. These are the decisions that that person may be called upon to make. Medical interventions, surgery, medications, testing, pain management, even to the point that if you're in a hospital and that hospital has certain rules because they may be religiously affiliated, maybe that's someplace that you wouldn't wish, maybe you're taken there on an emergency basis, but that's maybe not where you want your care to end up. So I'll talk some more about that later in the presentation. So the advanced directives are the form that will give you who's going to make the decision and what decisions you're going to make. And this is kind of what that form looks like. And it was developed with the Iowa Bar Association, although you don't need an attorney to fill it out. And it's best that you use the forms that are provided because each state may have a different form. So it's a matter of filling that out and then making copies and disseminating that so that the copies are available. Because again, if you fill out an advance directive and nobody has seen it, you don't know where it is, or your children can't find it if something happens to you, then it's really not of value. So you've got your power of attorney, you've got your document, so what do you do with that? Well, you keep a copy of the notes for yourself, you give a copy to your proxy, your power of attorney for healthcare decisions. You give a copy to who your medical caregiver is, so if that's at a clinic, that can be scanned into your record. And if you're admitted to the hospital, most of the time they'll ask if you have an advance directive. So if you do that, that can be scanned into your record there. If you travel and you're overseas, or if you are traveling to another state, you might want to keep a copy in your glove box. I thought about, we're still calling it a glove box, but nobody puts gloves there anyway. And nobody puts maps there anymore either with GPS. So anyway, making sure there's copies and that those copies are available is really critical. There is an advanced directive card that you can put in your wallet, so if something happens and the emergency personnel are there, you can just go online and say advanced directive wallet card, and you can download this. And this one that I have pictured here folds in half, so it doesn't take up too much space in your purse. The other thing about when you're planning for what you want at the end of life, and in the booklet I'll go through that with you in a little bit because it gets pretty specific about, well, what if this happened to me? What if I wasn't able to speak? What if I wasn't able to swallow and ingest food for my nutrition in terms of feeding tubes and that sort of thing? It's best if you kind of spell that out. And you don't want to use general language, no heroic measures, I don't want to be a vegetable, that sort of thing. That's not helpful. It's not specific enough. Nobody really knows what that means to you. So if living well means to you that Well, I want to be able to recognize my family members. I want to be able to enjoy food, and if I don't, and I'm rebelling against the food and spitting it out, and this gets, when we talk about dementia later on, that's another side issue. Maybe these are some things that you'll want to talk about with your family ahead of time. So be as concise and specific as you can. So the documents need to be signed in front of 2 witnesses with a notary public that can put their seal on the record. So if you change that at some point, you may need a new form. So keep that in mind. Now, there are some limitations to what an advance directive can be used for. I mentioned earlier that you have an advance directive and it's particularly useful when the patient is unconscious or in a terminally ill situation. But if you haven't had the dialogue, if you haven't had that conversation as only 3 and 10 have, then maybe that advance directive isn't as meaningful as it could be. If it's written 10 years ago and now your health condition has changed, the applicability may not be the same. So as your condition changes, you may want to keep up with any changes in the documentation. And again, lack of access, if they can't find the advance directive, they can't abide by what's contained and know who your power of attorney is. And then last is lack of enforcement. A living will or an advance directive is a wish list. It's not a command because physicians are not, and healthcare people are not required to abide by it, but you still have some choices if you meet a recalcitrant or obstinate healthcare provider, that you have some other options, and maybe as power of attorney, you will elect to take your care elsewhere for that person. Another thing that can be helpful is you can make a video supplement to that. So you can do that with a phone, you can do that with an iPad. You set it up, and what I would encourage you to do is you probably want to make a script for what you want to contain. So you want to start with, well, these are my values, these are my beliefs, these are the things that I really want for me. And then you can enumerate what they are. So if you do that, you can do practice runs because it's easy as just deleting and starting over if you make that video documentation. So you can indicate what the date is, where you are, and then you might want to limit it to maybe 5 minutes or so. So if you have your bullet points or whatever in that document, it'll be of more value. When you're done, close with a thanks or whatever. Good idea to review it, and if it doesn't meet what you want for yourself, to start over until you get to the point where it does meet what you want. And then save that and then disseminate that, which much like you would with the advance directive. So there are 5, we'll use D words, about when you may want to look at your advance directive again. First is if you go from one decade, you go from the 70s to 80s, 80s to 90s, whatever, probably a good time to review the document because there's a good chance that in your later years, that decade, there have been changes to your healthcare status. Death is another one, especially if it's your designated proxy who has died, you're going to have to find a replacement. And regarding the proxies, you can have one and you can have alternates, but they cannot be members of your healthcare team, cannot be, these are the people that sign the documents. They can't be your proxy, can't be your healthcare team, they have to be 18 or older. So those are some of the stipulations there. Divorce, and the other 2 are if you have a change in your diagnosis, particularly if you're adding another chronic illness to what you already have, something that's going to be with you and not managed acutely and then it goes away. Then your circumstances have changed. And then lastly, if you have a decline in your health and you're getting closer to the end, maybe it's a good idea to look at the document. The next form I'm going to talk about, as you may not be as familiar with, and that's called the Iowa Physician's Orders for Scope of Treatment. And this is what it looks like. And on the table, I have one if you want to pick it up and take a look at it for display purposes. This is another form that deals with your health in your current condition. So an advanced directive is about what happens much further down the line. This is, well, what if something happened to me tomorrow? So it's kind of the salmon color for quick identification. Any primary care physician should have this in their office, whether that's a family physician or an internist. They should have the IPOS, Physician Order for Scope of Treatment, available. So I'm going to talk about some of the things that are on the form here. This is again what the form looks like. So I'm going to talk about the top of the A, B, and C here. So the first one is cardiopulmonary resuscitation. So if you're found that you're not breathing and you have no pulse, do you want CPR to be initiated? Or not? My mother died 4 months shy of 102 years old. And at the end of her life, she had dementia and she had a fractured hip. And she had made a decision probably 2 years earlier that she did not want to be resuscitated if something happened to her. So she ultimately died. She was kept on pain medicine, and then she died. But she had made her DNR well aware of the care facility where she resided. The second category, your medical interventions, are you have to pick one of the three. Do I want comfort measures only? And if that's the case, they're probably not going to transfer you to a care facility. Or do I want limited interventions that would be short of being cardioverted or being intubated? And then full treatment means they're going to do everything they can. They're going to do CPR, they're going to intubate you if that's necessary, they're going to transfer you to a higher level of care. And then the last one is artificially administered nutrition. And we'll talk about why that's important again a little bit later, but that is, no, I don't want to be artificially fed under any circumstances, or if I have to have a feeding tube, I want it for X amount of time, or I'm okay with long-term nutritional support. Down at the bottom of the sheet, basically, it says medical decision-making and who's making this, and it lists the patient or durable power of attorney. And then over here it says, what are the rationale for these orders? And it says advanced directive, patient's own known preference, limited treatment options, or poor prognosis. And the back of the sheet basically is, information for the caregiver. Now, the thing about this sheet is it's only enforced if it's signed at the bottom by a healthcare professional. Now, that can be a physician, that can be a PA, that can be an advanced registered nurse practitioner, but it has to be signed to be enforced. And this form should remain with the patient, so it's transferred whenever there's a transfer with the patient. The other thing about the advanced directive I want to mention is I live at Edgewater, which is a senior retirement facility, and what we have there is we're encouraged that if we fill our advanced directive, we're given a red envelope. And so when the EMTs come from the closest fire station, what they do when they get to the apartment, if there's not another person there that can speak for the person in the apartment, because we have a lot of people that are a single widow or widower, and so what we're encouraged to do is put the advanced directive in a red envelope, stick this in a plastic bag, and stick it in the freezer So that's where, if they don't know what the wishes are, that's where the emergency squads will go to look first. So, again, it's some advanced planning, and so in our circumstances, that's how that would do. Again, now the position order for scope of treatment, this is common treatments, which we just went through, and this is in your current state of health, what I want, not with an advanced directive, which may be 10, 15 years into the future. So it has to be signed, and it should stay with the patient. And if there's any changes mentioned, it has to be notated on the form. So this form is particularly useful for the conditions that we have listed here. Somebody who's frail, somebody who has chronic disease, somebody who it would be a surprise if they died within the next year, or if they were a hospice patient. A little bit about cardiopulmonary resuscitation. It's performed if you're in a hospital, unless you have a DNR order or an advanced directive otherwise indicating that you don't want CPR. It's going to be done whenever there's surgery or a procedure, unless there's a form that's on the chart and accessible, unless it's not ordered. Those are the main things. And again, DNR, these are the critical things. And to have a DNR, it needs to be signed by a healthcare professional. So if you go to have DNR on your chest, so they see that. If you wear a wrist bracelet that says DNR, they'll only honor that if they have a written sheet of paper from a healthcare professional that says do not resuscitate. Now, if you are, a paramedic is called to treat you and you have a DNR order that they have looked at, it doesn't mean that they won't give you care, but they will stop CPR. They won't do chest compression, they won't do intubation, cardiac monitoring, administering drugs and that sort of thing. But it doesn't mean that you forego all treatments from the emergency squad. I mean, they'll keep you comfortable, they'll suck in your airway, they can give you oxygen if that's necessary, they can splint an extremity if there happens to be a fracture, control of bleeding, and they can help contact other healthcare providers. Now, one last thing I want to talk about in terms of healthcare is, and this is informed consent. So when you go to a hospital and you have a procedure or a test done, you're probably asked to sign an informed consent. And that means that you've been given the information that is necessary for you to make a reasonable assessment. So the mnemonic BRAIN, B-R-A-I-N, is one of the ways that you can think about this. So B is, what are the benefits if I have a procedure, if I have a test done, what do we hope to gain by this? Secondly, what are the risks that are entailed if I have a procedure? What are the things that could go wrong if things aren't optimal in terms of my care? A is for alternatives, and I think about this sometimes in terms of cancer care, because often cancer care will involve chemotherapy, radiation therapy, surgery, or some combination thereof. So I is insights in, well, what does this mean to me? How is this going to help my life long term? How will the quality improve if everything goes well by the procedure that you were talking about? And then N is, what if I do nothing? What if I decide that I don't want any more done? What then? Now I'm going to talk a little bit about Compassion Choices, which is a group I've been volunteering with for a long time. And Compassion Choices is the nation's largest and oldest volunteer organization that deals with issues at the end of life. So what the goals of Compassion Choices are is improving care, expanding options, and empowering people as they chart their end-of-life journey. So again, the nation's oldest, largest, and then there's about 7,500 volunteers nationwide. And I'll tell you what we're working toward in terms of making materials like this available. And also, I'm going to talk briefly about medical aid in dying. Now, this is the brochure that I encourage you to pick up because this is the one that will serve as your guide about what are the things that will help me in my planning. So this is the booklet that's on the table. This is the table of contents, and you start at the beginning about what's important for you, and that's where you build what the decisions are as you go forward to fill out these forms. Another thing is a dementia provision, and why that's important is that by the age of 65, 5 to 8% of the population will have dementia. And that increases by that number every 5 years. So that as we extend our lives, 1 in 3 people will have dementia at the time that they die. And so why that's important is because it's harder for you to make decisions once you're in that loss, you have cognitive decline. So that's important to have that discussion about, well, if this happened to me, and I mentioned earlier about, well, what if I have dementia, but I don't want to eat, I spit the food out or whatever, is that really quality of life from that standpoint? So this is just some of the things, and again, at the top here, I spit out food, I put food in my mouth, and I cough or gag. These are things that they're probably going to be well into the dementia, so it's best to have this done before that happens. The other thing, there are some other forms in here, and one is the sectarian healthcare directive, because I mentioned earlier about there are some hospitals that have religious restrictions about things that they will and won't allow in that hospital. So if that is impairing your loved one from being treated the way they want, and you have power of attorney, you can request that that patient be transferred to a different facility where their wishes will be honored. This isn't probably too much of a problem here, but hospital visitations in the past, they could block people from seeing someone when they're in the hospital. Something we probably wouldn't think too much about, but if you have, this particularly was applicable to the LGBT population, that sometimes a family member would keep a loved one from seeing someone in the hospital because someone had a grudge against that. So the treatment options that you have at the end of life, having treatment, refusing treatment, discontinuing treatment, hospice care, which I can't say enough good things about because both of my parents went through hospice care and they do an excellent job. And then it talks about voluntary cessation of eating and drinking. And while there are 13 jurisdictions that have medical aid in dying, which I'll get to shortly, you can stop eating and drinking in all 50 states. There's no laws against that because it's a personal choice. So if you are of a sound mind and you reach a point in your life where you don't want to go forward, you can, on your own, say, I don't want it anymore. I will stop eating and drinking. It doesn't mean you can't keep your mouth rinsed out or your lips moist or whatever. And this is something that may take 14, 20 days or whatever, but you gradually stop living. Now, medical aid in dying, I want to talk about this because this started back in Oregon more than 26 years ago. They were the first state to pass, it's called Death with Dignity, and it allowed, these are kind of the provisos, it allowed terminally ill patients who had prognosis of 6 months or less to live, that they could make the choice to take medication that would allow them to die peacefully. So the patient has to be mentally capable to do that, and they have to self-ingest the medicine that is provided for them. Now, the other thing about that is this process is entirely voluntary. It's voluntary on the part of the patient, it's voluntary on the part of the healthcare providers, it's voluntary on the part of the pharmacist who makes the medication available. And the biggest thing is a lot of people think about Dr. Kevorkian and the things that he rigged up, which were infusions. This is something that you have to be able to take the medication and ingest it yourself. This lady that you see in the picture is Brittany Menard, and Brittany Menard was a 29-year-old woman who back in 2014, January of 2014, she was diagnosed to have an astrocytoma, which is a form of brain tumor. Brittany had graduated from University of California at Berkeley in education. She then went to the Southeast where she taught for some time. She came back to Berkeley, got a master's degree, got married to a man named Dan Diaz, and then she began having headaches and seizure problems, and they diagnosed her to have astrocytoma. So they did surgery in January of 2014. By April, the tumor had expanded, and she was diagnosed to have a glioblastoma, which is basically an incurable type of brain cancer. It can't be treated with chemotherapy, radiation, or surgery. So at that point, Brittany and her husband Dan were living in California, and at that point, California did not have medical aid in dying. They do now. So they made the decision to move to Oregon to become residents there so that she could avail herself to medical aid in time. So she did that in November of 2014. She took the medication. Her loved ones and family were with her when she did that. And so Brittany was 29, and the average age of people dying in Oregon is 71. So this is kind of a wake-up call. This is the picture that appeared in People magazine telling the story about what she and Dan chose for her to end her life peacefully and not going on with the ravages of the brain tumor. So medical aid in dying is available in these 12 states. It was mostly on the West Coast, so it kind of moved from Oregon, Washington, California, Montana, Hawaii, and we move across, and New Mexico has it now, Colorado, and then states in the east. In the last year, Illinois and New York were added to have this, so now 20% of the U.S. population can have medical aid in dying. And in Oregon and in Vermont, you can go there as a non-resident, and you can be given the medicine, but you have to take it within the state. So you can't go to get the medicine and go back to wherever you came from. So as I mentioned, this is an entirely optional type of process. In a 2018 Gallup poll, it was supported by 72% of Americans. And in more than 70 years, with the number of states and also the District of Columbia, there had not been a single case that has gone that showed coercion on the part of the person who took the medication. The other thing I should mention is that there are probably only a third of the people who have asked for the medication actually end up taking it. So what they want is the option if their plight becomes to the point where they say, this is it, I'm ready to be done. Only a third of the people take it, but they die knowing that that option was available to them if they desire. Now, I work with the Central Iowa Action Team for Compassionate Choices, and And we have been submitting bills in the legislature for the past decade. Most recent the recent ones have been called Our Care, Our Options Act, and these are the provisos of it. What has happened as time has elapsed, because this was kind of the early tenets that you had to have 2 oral requests 15 days apart, and you had to wait 48 hours to write a written prescription, and it just kind of dragged the thing out. And people said, well, why do we make people wait this long for something if they want to have this available? So in many of the states, they have shortened the time period between when you can request it and when you can actually receive the medication. So again, it's voluntary. You're not forced to participate if you don't want to. This is a book that I want to mention. It's listed in the reference. It's called Finish Strong. It's just an excellent resource. It was written by Barbara Coombs-Lee, who is the president emerita of Compassion Choices. She was a nurse practitioner, physician assistant, critical care nurse, who was, and later got her JD, who was instrumental in the passage of the Death with Dignity law in Oregon. And so the 2 main organizations that are involved with end-of-life issues and support for medical aid and dying are Compassion Choices and Death with Dignity. And they're both headquartered in Portland, Oregon, not surprisingly, because that was the first state to enact the legislation. And I wanted to just read this quote from Barbara Coombs-Lee. She writes, "The terminally ill people with whom I work want very simple things. They want to avoid suffering. They want effective pain management. They want to remain lucid and engaged with life as long as they possibly can. They want assurance that their treatment decisions are well informed and don't subvert their primary values, priorities, and the quality of their remaining months or years. They want options that can allow death to come peacefully when it comes." So the last quote I'll leave you with, and then I'll take any questions that you have, from Helen O'Shaughnessy. "The greatest human freedom is to live and die according to one's beliefs and desires." That's what we wish for everybody. Thank you for listening. Appreciate it. Are there any questions, comments, thoughts? Yeah, Marianne?
I recently learned that there are a new emerging professional group called death doulas. And I haven't really seen Compassionate Choices talk much about them yet, but I know we have some in Iowa, correct?
We do. The word doula is kind of, you've probably heard of birth doulas. They were basically people who were trained to help women in their prenatal and through their delivery process. So they, as an outgrowth of that, they have developed a certification program. I think it's done through the University of Vermont, Burlington, where death doulas take training, and basically they will help people in their final days, weeks, months. So they may be helpful to help people get their advance directives in place. They may be there just to serve as a sounding board, to be there because they may not have family members that can fulfill that role. Another thing I'll mention is you may hear Death Cafe, and Karen and I went to our first week before last. It was held at the Franklin Library. The next one will meet it's either the first or second Wednesday of the month. And it's led by a death doula. And basically it's just people sitting around talking about their thoughts, fears, maybe what a loved one in their family had gone through. Because some of them will say, "I watched my mother and it was terrible. She suffered and I'm sure that she didn't want that for herself, but, so anyway, that's what death doulas are. There are several around the Des Moines area. There's a lot more of them actually in Johnson County. So it's another thing that, and you can just Google death doulas and you'll find more about them. And you can even Google, say, who are the death doulas in the metropolitan area, and they'll give you a listing. So, yeah, it's a different calling that people have. Yes?
I have tried to have the big talk, the later talk, not the early one when they're teenagers, with my kids. Both them flat out refuse to even discuss. One of them is a Christian. One of them I don't know, I don't ask, I don't know. Could I do this and have some sort of entity, I was thinking an attorney or something to do this with and have them have the information so that when my end is getting near and I, you know, they both do agree with my, you know, my plans for my end of life and what happens after I die and such, but, like other parts, like, you know, I had one son screaming at me because I don't want to hear him. And I mean, he talked to his brother and now neither one of them will talk to me about it. Is there a way that I can have an independent entity to oversee those things?
Yeah, and I realize that for some families, it's hard to have that talk. They don't want to have the talk, they don't agree with what you want. And that's why for power of attorney for healthcare decisions, you want to be very intentional about who you pick for that role. So it may be a close friend, it may be a neighbor, it's somebody who you think knows you pretty well, or someone that you have an ongoing conversation with about, this is what I want for myself. Because the power of attorney really, it's something that if you have a document and this other person's name is on it, then the family, you know, they're not empowered to make decisions on your behalf. And we always used to talk about that when I was in practice, and sometimes it was the family member that lived farthest away that had the least contact with their loved one, often a parent, and they would come in from either coast and they said, I want everything done that we can for mom or dad. And I think some of them do that out of a sense of guilt because they haven't been there to have the conversation, to really understand what mom or dad want for themselves. So to assuage their guilt, they say, well, let's just do everything, which may be countermand what they want for themselves. So, and once you do that, I'm thinking that it's probably a good idea to let your attorney know what your circumstances are about who you pick for your power of attorney, and so that your wishes are followed. Because you're probably going to do with your attorney for other parts of it, your last will and testament, power of attorney for financial decisions and things of that nature. Yeah, I wish you well.
Thanks. Thank you.
Yes, Becky.
In relation to that question she was asking me, to that you gave, I was thinking about how the physician needed to sign some of those forms that said, like that salmon colored form, so that, you know, sort of those wishes could be implemented. How does that work then, that the physician would, you know, is it, I'm just trying to picture what people have to be in the room at the right time to get that all signed and official.
Yeah, and what I would say is, for like the I-post, you have to have where the healthcare professional is, and this really is, the signature is going to come at the end of an extended conversation. so that we just didn't check these things. They said, now, they're going to say, do you fully understand what you're asking under this circumstance? So that's why an extended visit may be necessary, because this isn't a 10-minute, we'll check this off and sign to that. It's the same thing with the advanced directive. It requires some diligence and time. And one might say, well, what have I done? Well, I've been giving these talks for many years, and I decided, well, it's pretty critical of me to stand up here. I've done these forms. I've gone over them with my wife, I've gone over with my children, so I kind of understand my wants and wishes, and they're on board with that. So they have copies of the advanced directive and things of that nature. So, and that I'm probably going to need to have that conversation again in another couple of years, just so everybody's clear about what the wishes are. But I encourage you, if you haven't gotten started, think about it and initiate that effort. I mean, that's how you hopefully will get what you desire. That we all dream that we're going to fall asleep and we're going to fall asleep and we're never going to wake up. And the reality is that is fortunately how some people expire, but not everybody. And so it's not always that peaceful. So what you want to do is avoid things, interventions that go against what you want for yourself. Again, thank you all for